Women who are overweight have a 20% increased risk of breast cancer, and if they're obese, it's 40% increased risk. Hormone therapy doesn't increase. The worst outcome study hasn't shown a 40% increased risk. It is not healthy. As a society, we are overweight and obese.
Welcome to the Proof Podcast, a space for science-based conversation exploring the health and longevity benefits that come with mastering nutrition, physical exercise, mindfulness, recovery, sleep, and alignment. Facts, nuance, and trustworthy recommendations, minus the hyperbole. A few weeks back, I sat down with endocrinologist and Professor Susan Davis to discuss the best practice guidelines for menopause. To say that this episode was popular is an understatement, with feedback coming from women and men all across the globe who found the episode to be extremely helpful. There were, however, a wide range of additional questions and areas of menopause that people were curious to learn more about. I read your messages, listened to your voice notes on Instagram, and invited Susan back to sit down for a Q&A episode. Is the Dutch hormone balance test worth the cost? Will a woman get osteoporosis if she doesn't take HRT, hormone replacement therapy? What can a woman do to improve bone mineral density if she has a history of cancer? What else can a woman do to lose weight around the midsection? What is early menopause and what causes this? We cover all of this and more, jumping around a little bit more than our previous conversation, tackling the most common questions that I received. For those who are coming across Susan for the first time, Susan is a clinical endocrinologist, a professor at Monash University, where she's currently running several double-blind placebo-controlled clinical trials looking at testosterone therapy and women's health outcomes, and is a key member of the International Menopause Best Practice Guidelines. With that, please enjoy part 2 of All Things Menopause with Professor Susan Davis. Professor Susan Davis, welcome back.
Hey, thank you.
Yes, I'm very excited to have you back in here. Last conversation was fun, and as I just mentioned off air, we received an immense amount of positive feedback from that episode. So looking forward to kind of emphasizing some of the main key learnings from that episode, and then building on a few of those things, digging a little deeper. With the help of the community, I have a bunch of extra questions and some of my own as well. I thought it could be good to start with some of the feedback that the community shared. And I know you're very humble, so I don't mean to embarrass you here, but let me read a few of these. Until I listened to your podcast with Professor Susan Davis, I assumed I just had to struggle on, that this was my new reality. Achy joints, night sweats, constantly tired, and an emotional wreck leading to deteriorating relationships with friends and family. One of the best podcasts I've ever heard. Thank you so much. I now feel much more confident speaking with my doctor. How can we make this information mainstream? This is fundamental knowledge. I love Dr. Davis's no BS evidence-based approach. I think I might have sent you this one. No sugarcoating. She says it how it is and backs it up with science. Music to my ears given the number of pseudo-experts we hear talking about female hormones and menopause that bash hormone replacement therapy while profiting from their own supplements. This is why I tune into the Proof. How does that feedback make you feel?
Well, it's very gratifying because there's no point doing what I do if it doesn't translate into making a difference in the community. And part of that making the difference is empowering women and their families and their partners with knowledge. And if you understand what's happening in your situation, you're more empowered to do something about it, whether it be your health, your financial situation, whatever it is. So the more knowledge we have, the better off we are.
Yeah, it's certainly, this is just a handful of the feedback. There were, between the YouTube, the Instagram, and the emails, there was hundreds and hundreds of comments, and all quite similar. And for me, I actually felt an enormous sense of pride because as this show has grown, and it's grown a lot bigger than what I ever imagined at the beginning, I've kind of felt a degree of personal responsibility around who do I platform here, because it's such a big decision. Am I getting true experts with domain-specific expertise who have decades of understanding of a particular topic and can speak objectively on it and communicate the nuances? Or am I getting someone on who could potentially mislead? So it was nice to kind of have my decision to get you on sort of reinforced through the community's feedback. And that does get me thinking. I sent you a video recently. I think it was yesterday I sent you a video and you said, let's make sure we talk about that. And 99% of the feedback that came through was all positive. And then some of the feedback was, well, have a look at this. Here's someone else with contradictory information. And I'd been sent a couple of videos of a woman who, her name's Mindy Pells, I believe, Dr. Mindy Pells, and this is not to call her out individually, but I think this is a good example of potentially some misinformation that people could come across. And I'd been sent a few of her videos, and she sort of takes a very alternative, natural approach to managing the symptoms of menopause. And I was curious to kind of look at her qualifications. You know, she has doctor in front of her name, but it wasn't immediately clear. And on her website, there was a bachelor's degree of kinesiology, I believe. No mention of a medical degree, but a number of people that had messaged me sort of were under the assumption, with the confidence that she was talking about sex hormones, that she must be an endocrinologist. But in fact, she is a chiropractor. And I'm interested, you've been in this space for a long time. How important do you think it is for people to be clear as to what their qualifications are to prevent the chance of misleading someone?
Okay, I think there are two issues here. I think what is the individual's qualifications and what is the person's conflict of interest? And I remember being at a presentation many, many years ago, and one of my colleagues from America, we stood on the podium, gave our talks, and one of my colleagues was asked, well, you've said this, but someone else says that. Who do I believe? And his answer was really good. He said, look at what the agenda is of the person speaking. Are they trying to sell you something? Are they an evangelist for their belief? In those days, there was a big anti-hormone replacement sentiment. This is 30 years ago. And sort of people saying, oh, menopause is natural. You shouldn't take those nasty drugs from those nasty drug companies. But then had they just written a book that they were trying to sell? I mean, so what is the person's qualifications? What gives them the knowledge? Where is the evidence that they have a knowledge base to be authoritative? But also, what is the potential conflict? My potential conflict is I do medical research. I want everybody to think my research is really good, so the government funds me. I do consult with drug companies, but I'm also known for very much telling drug companies what I think, not what they want to hear. So we're all conflicted, but try and decide how deep that conflict is.
So what do you think those conflicts of interest are when someone is sort of pushing the more alternative medicine, natural kind of narrative here, specific to menopause?
So their conflicts could have been they've had a personal journey and they've become evangelical about what improved their health. For example, it could be exercise, but then not everybody's going to exercise like they exercised. It could be that they've got a book they're selling and they want you to buy their book and they want to be famous. It could be that they're actually, if you look a bit deeper, they're selling a product. They may be involved in some alternative medicine that they have a financial gain from you believing them. So try and understand what their conflict could be.
Yeah, when I looked at this doctor's website, it was quite clear there was a lot of supplements being sold, courses for $4,500 and a whole bunch of things. And actually one thing that was being sold on her website, which leads in nicely to a question that came in from the community, was a Dutch test. I was interested to know, someone asked, I'm in perimenopause and was advised to do the dried urine or Dutch test to assess hormonal imbalance. Is this superior to a blood test?
It's just as much rubbish as a blood test. So if no reputable group recommends any form of blood testing to diagnose menopause for a woman aged over 45. Because if you have the symptoms and if you've got a uterus and your periods have become irregular, it's a clinical diagnosis. And the reason no test is useful is you could test on 5 different days of the month and all look as though you're premenopausal because the hormones are going up and down like a yo-yo. Or you could do 5 days a month and have a classic postmenopausal appearance of your hormones. So we don't use hormone testing at all to diagnose menopause in someone over 45. In a younger woman, we do use standard hormone testing, and the Dutch test is not going to tell you more than a regular blood test.
Okay, thanks for clearing that up. One other claim that this doctor has made that's been sent to me, and it is kind of off topic with regards to today's focus, but I want to ask you while you're here, and I think I need to dedicate a separate episode to oral contraception, birth control. But this was sent to me, and I think young women particularly will be interested about this. The claim is that birth control is a major disruptor of a natural cycle, and then the sort of insinuation that birth control will negatively affect a woman's ability to conceive later in life. Is there evidence that you know of that would support that?
The way that combined oral contraceptive pill works is by stopping ovulation. And by stopping ovulation, women have control of their fertility. So yes, it's disrupting a normal cycle. Absolutely, that's how it works. That's how it's meant to work. If women would like to control their fertility, that's one of the most effective ways of doing it. And women have a choice whether they do or don't want to do it. Does it lead to infertility? No, absolutely not.
So it doesn't lead to infertility,
No.
But does it reduce the chance of falling pregnant?
No.
No. So where's that come from?
Look, there are different stresses on young women that we see today. So in my generation, we took the pill. We took much higher doses of the pill than are available today. And there was no issue with infertility or delayed fertility or trouble getting pregnant. But one of the most common reasons that women struggle to get pregnant is leaving it too late. So fertility dramatically drops after the age of 35. That's not new. In my generation, it was applied and applies. So women are leaving it too long to get late to get pregnant. And secondly, life stress impacts the central brain mechanisms that control the ovulatory cycle. And women are just stressed out of their tree more than I think ever before. So managing stress, healthy lifestyle, and not delaying your timing of when you want to conceive.
What's the optimal time to conceive, do you think?
Before the age of 35.
Before the age.
Once you get over 35, so when a girl's born, they've got millions of eggs in their ovaries. And even in the first 12 months of life, there's a massive reduction in the number of eggs. And then that gradually declines from childhood through puberty till the age of about 35. And then there's this steep, slippery slope where the number of eggs just start to disappear from ovaries.
Yeah, and some women will enter early menopause, which we briefly spoke about, and I have a number of questions specific to that I want to get to. I thought it could be good to kind of summarize some of the key takeaways first before we get into the questions from last episode. In case someone hasn't listened to that episode, I recommend they go back and listen to it, or just wants a bit of a refresher, myself included. So feel free to kind of correct me on anything that I summarize here. But we established that the average age of menopause in Australia is 51 and a half years old. Globally, it's tends to be between 47 and 51. You could call it 48.8 or something. I think one of your papers established is kind of right in the middle. And perimenopause typically lasts for 3 or 4 years. And that goes up until 12 months after a woman's last period.
Yep, if she's menstruating.
If she's menstruating, right. Which can make this all a little bit trickier
blurry
to navigate. So again, I think you use the word textbook woman. So we're talking about a little textbook woman here. And 12 months after the last menstruation is when a woman knows that she's reached menopause, which is a sort of moment in time rather than a period, if I recall correctly. And so after that, 12 months after the last period is then the postmenopausal phase of a woman's life. And that accounts for around 1/3 of a woman's adult life.
Well, as the average female born today, the average expectancy in Australia is about 100 years of age, so it could be half a woman's life.
Mm-hmm. Gotcha. So we're talking a long time, and I think there's over 1 billion women that are in that phase alive today.
That I couldn't.
Right.
Possibly.
I think it's around that. So we're not talking about a small number of people.
No, it's half the population.
So this is a very important issue. And in terms of the symptoms, they usually start during the perimenopause period. That's you described as hormone chaos. So lots of things are changing, particularly estrogen going up and down during that period, irregular menstruation. A woman could still fall pregnant in that period. And we talked about hormone replacement therapy as an option to help reduce some of particularly the vasomotor symptoms, vaginal dryness, and I think we spoke about night sweats. Does that fall under vasomotor? Yeah. And then we also spoke about some of the potential benefits with regards to reducing risk of certain chronic diseases that a postmenopausal woman has increased risk of, such as osteoporosis and potentially cardiovascular disease.
And also the mood changes as well. So some women get, I think the most common mood symptoms, in fact, anxiety. Not severe depression, but anxiety is common.
And we also cleared up who may be contraindicated for hormone replacement therapy. We spoke about the fact that it's not indicated if someone has a history of breast cancer usually. I believe it was ovarian and endometrial cancer as well.
No, breast is the main one.
Just breast cancer. Thank you for correcting me on that. I knew that would occur. And we spoke about the fact that the indication is for commencing hormone replacement therapy within 10 years of menopause.
So it's quite interesting about that one because I've been writing a review article for a major journal and I've gone back and delved into why we're saying this. And it all comes from the Women's Health Initiative study. And in that study, without labouring it, it only included women aged over 50, but up to the age of 79 years. And the first publication showed that for women aged 50 to 59, the estrogen only was associated with possibly even a reduction in heart disease, but no increase. But for women aged 50 to 59 who took estrogen and progesterone, there may have been a small increase in heart disease. But if they were within 10 years of their menopause, there wasn't. And that was a very specific formulation that was also associated with thrombosis and gallbladder disease and other things.
When you say that's a specific formulation, that differs to what you would be prescribing today?
We rarely prescribe this combination today. So then you've got, so don't take that as the gospel. That's what was talked about. And suddenly everyone's saying, oh, within 10 years of menopause or under the age of 60. But then you start looking at it and go, okay, there's now been a 20-year follow-up from that study. And the women who took HRT versus placebo, now there are 27,000 women in this. This is not a little study. This is 27,000 women. There was no difference in all-cause mortality, cardiovascular mortality, or cancer mortality in the 20-year follow-up of women who were 50 to 79 at baseline. So now 70 to 99.
But they'd been taking that the whole way through.
No, there was an average usage was about 5 to 7 years.
Okay.
But the point being was a third of these women were over the age of 70 in this study when they started. And there's been no harm done. So you've got to go back and say, hang on, why are we running around and parroting this concept of under the age of 60 or within 10 years of menopause? It doesn't really hold water. It didn't affect chronic disease at all, really. And we don't even prescribe that therapy anymore.
So I think there's two things we need to double click on here that were common questions that came through, just to make things super clear. So let's first take the example of a woman who commences HRT at, say, 51 and a half.
Okay.
She's just entered the postmenopausal period of her life. The most common question I got from that woman was,
how long?
I'm on HRT, yes. How long do I continue to take it? Do I take it for 10 years and then I can assume that if I come off, I won't have these acute vasomotor symptoms? Or should I just continue it to get the possible benefits for risk reduction for osteoporosis, for example?
Okay, so the how long is the easiest question. Every major guideline now in the world says as long as there are still individual treatment goals and that each patient has regular review of the benefits versus the risks. So if you've got a woman with low bone density, or if you don't have a bone density machine and you're in a less developed country, very skinny woman, you are going to be protecting her against bone loss, and you might choose to continue for longer. But there's no cutoff at 5 years or line in the sand at 10 years or even at 20 years. And there'll be women who will forget to take their tablet or put on their patch or their gel for a few days, and they'll have no difference in their symptoms. They feel fine and they know they can stop. And there'll be other women that, they say to me, oh no, I never forget a tablet or a patch because if I do, the symptoms are horrendous. Well, they continue and we might gradually lower the dose. So it's individualized. There's no line in the sand.
So if there's no family history of, say, osteoporosis, and if they were to go and do like a DEXA and their T-score was normal, then that's someone that you would be happy sort of coming off of the HRT.
Yeah, I don't get too strung out about family history of osteoporosis either because our parents' generation didn't have the nutrition and the health that we have. So I think it's the personal history of fracture, other health conditions, risk factors for osteoporosis. And if you are able to do a bone density, not everyone can, then you would take that into account as well.
Okay, that's clear. The other scenario. So a woman is aged 62. She's a little more over 10 years from menopause for her. What does she need to consider with regards to whether she can commence HRT?
Okay. Well, the thing about this that's confusing is the guidelines that keep popping up are less than 60 or within 10 years of menopause. So if our 62-year-old lady went through menopause at 55, she's within 10 years of menopause.
Let's say that
the guidelines are pretty sort of messed up, really. But if she went through menopause at 51, she's got horrible symptoms, I'd still treat her. Taking into account, though, other risk factors. So if she had uncontrolled hypertension, I'd treat that first. I would look at other health components, but I would still treat that person because she needs treatment. I would use the most conservative therapy available to me, but I'm still going to relieve. If she's waking up 3 times at night drenched in sweat, I'm going to treat her.
You alluded, or not alluded, you made it very clear that the formulation in the Women's Health Initiative is different to what you would mostly prescribe today. Perhaps you could just comment on sort of how your views have changed over the years with regards to your preference for the form and or dose of HRT. Has much changed over the last sort of 20, 30 years for you?
I think perhaps the greatest thing that's changed for me is that we get hung up on dose. And I learned a lot about this from research, because I get to see data that other people don't get to see. So let's take it, to simplify it, let's look at the estrogen patches. The doses are 25, 37.5, 50, 75, and 100 micrograms. We've got 5 doses. Why is it that some people can put on a 25 patch and get fluid retention and sore breasts, but their hot flushes have gone, and other women put on a 100 patch, they have no side effect and they've still got some hot flushes? And there are several reasons behind that. One, the absorption varies between women. So some women with a 25 patch can get a higher blood level than someone with a 100 patch. 2, the blood levels aren't the be-all and end-all. I might need a higher blood level to activate my receptors than another woman. So
because they might be less sensitive.
Yeah, my tissues might be less sensitive. My brain tissue, my bone tissue might be less sensitive. So we can't assume that higher doses are necessarily bad and we've got to get this person on a lower dose. Oh, I don't want to take this big dose. Well, if you're on a 50 patch and it's not working, but a 75 patch does, it's really that biologically you're different. And the analogy would be, in the middle of a menstrual cycle at ovulation, some women ovulate with an estrogen level of 500 and other people ovulate with an estrogen level of 1800, so more than 3 times. So our bodies are all different because our tissues have different sensitivities. So I think the greatest thing I've learned is not to get hung up about dose and manage each individual person.
And I should have mentioned in the summary, the goal of hormone replacement therapy, we made clear in the last episode, is not to restore the levels of hormones that a woman would have during her reproductive years, but to get a certain blood level that helps reduce symptoms primarily.
Yes, and the blood, we don't measure blood, we don't treat to a blood level, because what will alleviate one woman's symptoms may be either not enough or too much for another woman. But when it comes to bone, you don't need very much estrogen to protect bone.
You mentioned estrogen receptors in the brain. How does low estrogen affect brain health, cognition? Do we understand that?
No. So it's sort of also interesting that there's this real cry from women that the main thing that's bothering them is their cognitive function. This seems to be a new thing in a way, because most women tended to be worried about flushes a few years ago. During the perimenopause, when the hormones are going up and down, is the time where women are most likely to experience awareness of changes in their brain functioning. And most of this is word finding, short-term memory, and concentration. But it tends to improve as women go past the perimenopause. So if nothing's done, it does tend to naturally improve. So it may just be reflecting the chaos of the hormones, not absolute blood levels, because after menopause, the levels are very low. The other thing is that we assume it's directly due to estrogen in the brain and brain cells functioning and networks in the brain functioning. But what also is happening at this time is terrible sleep. And poor quality sleep is one of the greatest risk factors for dementia. I'm not saying everyone at menopause is going to suddenly get dementia, but I'm saying is that if any individual reflects on a time in their life where they haven't slept well, your brain doesn't work very well the next day. If you've had a period of stress and poor sleep, it's shocking for brain function.
But what causes the poor sleep?
Often hot flushes.
Right, but what's causing the hot flushes?
The chaotic estrogen.
Right.
But it may be, the mechanism may not be a direct effect on the brain, maybe indirect through poor quality sleep. And it's fascinating that giving HRT does not objectively improve measures of cognition.
I want to come back to indirect and direct when we talk about weight gain, because I think there's some relevance there as well.
But if you look at any study that has looked at hormone replacement therapy and cognitive function, the big studies, you do not see an improvement in cognitive function with HRT.
Short-term cognitive function.
Any domain of cognitive function.
Do we have any data on, say, women who have had breast cancer and have had pharmacotherapy to lower estrogen, whether they're at increased risk for dementia?
That's complicated. In fact, we almost got an NIH study, a study funded by the US to do that. The problem you've got is controlling for the stress of having had breast cancer and chemotherapy. Because chemotherapy, you get chemo brain. And so there's chemo brain's been well established.
What's that?
So after chemotherapy, people, not just women, will experience change in cognitive function. It diminishes,
Is that because it's just indiscriminatory in its action and it's affecting neurons?
Well, again, is it related to suppression of there's so many mechanisms. The inflammation that you might get after chemo, it could be direct effects on the brain. It could be, chemo's poison cell. There are a whole range of things, but is it just the exhaustion, the fatigue? Who knows? But it's well described. So teasing out whether lowering estrogen after breast cancer impairs cognitive function. Some women complain terribly of it and other women say, I feel fine. Very hard.
Is there anything that you've used clinically or any advice you've given to a woman who has been struggling with cognition that has been of benefit?
Oh, getting sleep and less stress. And yes, if you treat the hot flushes and night sweats, women do tend to improve quite a lot. Women will come and say, I can think again, I've got my life back. But is it directly estrogen effects? People talk about menopause alters brain structure. I think it's still unclear.
Right. Sleep deprivation has a knock-on effect of many things. It could
everything.
Affect the type of food you eat, how much exercise you do.
Exactly.
How social you are.
Yeah, it's complicated.
Yeah. The lady who connected you and I won't mention her name, but she's a friend of mine, a sort of professional colleague that's helped me professionally over decades now at this point. She actually entered early menopause. So in her 30s, her period stopped. And I did have a number of questions about early menopause that came through. So perhaps we can dig into that a little bit, starting with, from a definition point of view, what is early menopause?
So the definitions are very much for people of European ancestry who go through menopause at an average age of 50. I say that because if you live in India, the average age of menopause is 47. So obviously early menopause, 45 is not early menopause. So people of European ancestry, by definition, premature ovarian insufficiency, which used to be called premature menopause, is before the age of 40. And early menopause is from the age of 40 to 45.
Got you, because those two terms are sometimes conflated.
Yes. So early menopause is, strictly speaking, between the ages of 40 and less than 45. And premature menopause or premature ovarian insufficiency, we often call it POI, I'm going to sneeze in a minute, is before the age of 40.
And with premature ovarian insufficiency, am I right that there is a primary and a secondary version of that?
So the language gets really messy because primary is usually referring to having never menstruated ever. So there are some girls with genetic abnormalities that will never menstruate. And secondary is you've menstruated, but then your ovaries stop functioning. Or you can use it in terms of primary, it's an ovarian disorder, and secondary, it's induced by chemotherapy or radiation therapy. So the language is often very messy. And in the end, you can have a genetic disorder like young women with Turner syndrome, where they've got genetic disorder and their ovaries stop working. Some of those young women never menstruate, and some have a couple of menstruations and then never menstruate again. So sometimes the definition's not really that helpful.
I had a comment come in from a lady said, I was told by my doctor my symptoms cannot be perimenopause as I'm 42. Is this true?
That's complete nonsense. I mean, of course. I mean, she could have early menopause.
So what could cause a woman to have premature ovarian insufficiency and her period to stop in her 30s, and what could cause early menopause?
Well, again, we put this line in the sand of 40, but really is a 39-year-old very different to a 41-year-old? So although we say menopause before the age of 40 is this thing and after is that thing, it's a bit of a
kind of one bucket.
Yeah, it's a bit of a moving feast. So let's just call it early menopause. The majority of cases have normal genetics and no cause is ever identified. Normal genetics to what we can measure. But very frequently there's a positive family history of a person's mother going through an early menopause or a sister going through an early menopause. So it's something familial, but we can't identify it. Then it sort of just breaks down in sort of equal groups of about 10% are associated with autoimmune disease. So someone who's got thyroid disease, adrenal insufficiency, some other autoimmune disease in the family, diabetes, rheumatoid arthritis, etc. And so it's an autoimmune cause affecting the ovaries. So we always check for thyroid function, etc., in young women with early ovarian failure. There are genetic causes. I mentioned Turner syndrome, and there are other genetic causes, but the most common is actually Fragile X gene mutation. This is a genetic mutation that progresses through generations. So it becomes amplified through. So if I've got a few changes and then I have a child, they might have some more changes with no clinical features. Then they have a child and the gene changes over time.
As in progressively greater and greater chance of premature ovarian insufficiency.
Well, so it's once you get these genetic code repeats, and the number of repeats increase and increase and increase. So normal's less than 44, say. And once you get between 44 and 200, then of repeats, it's just like going blah, 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 blah repeatedly in the gene. That once you get all these repeats in the genetic code, it's called the premutation, and that's associated with early menopause. And then once you get the full-blown mutation, you start to see autism. It's one of the most common genetic causes of autism.
So if someone has that, more reason where possible, where in someone's control to have kids earlier rather than later?
Having kids early, well, they need to be, if someone has that genetic mutation, they also need to be aware that they could potentially have a child with autism. It's perhaps the more important thing. And so that's where knowing what risks there are and family history is critical to decision-making about fertility.
If someone has premature ovarian insufficiency, and I understand you've just outlined there's a number of different potential causes, so this could vary case by case. Once someone's diagnosed with that, is there still the chance that they can conceive?
So we didn't talk about radiation therapy, chemotherapy, and a lot of people are surviving childhood cancers now. So that's an increasing number. So putting the medically induced early ovarian failure aside, the chemotherapy.
Does a hysterectomy fall into that as well?
No, you have to have your ovaries removed, not just your uterus. Mm-hmm. I mean, you can't get pregnant if you haven't got a uterus, but if you need your ovaries removed to surgical menopause. So of what we call spontaneous premature ovarian insufficiency, so no clear genetic mutation, not medically induced by drugs or radiation, etc. Of women with spontaneous premature ovarian insufficiency, about 15% can conceive. So we never say to those women, you are absolutely infertile, and that's why we don't put those women on the pill to give them hormone therapy, because if they want to conceive, obviously if they're on the pill, they're not going to conceive. So the likelihood of getting pregnant is remote, but not impossible.
Does it ever have to do with the pituitary gland and like LH and FSH?
So the ovaries are controlled by the brain. The most central part's called the hypothalamus, which is right in the center of the brain. And that sends messages to the pituitary, which makes hormones, FSH and LH, which then stimulate the ovaries. The ovaries make hormones. The hormones feed back onto the brain and tell the brain, hey, we're working. So you can get abnormalities in the production of FSH and LH from pituitary tumors. But things like if you're making too much of the hormone prolactin that causes breast milk in breastfeeding, that'll stop you menstruating and ovulating, but that's reversible. So it's not premature ovarian insufficiency. But there are some times where the brain is not making these hormones from birth. One of them is called Kalman syndrome. And in that setting, women have a brain cause of their ovaries not working, but they can still get pregnant because we can stimulate their ovaries.
Mm-hmm. Okay. So to recap, though, if a woman is in her 30s or early 40s and notices irregularities in periods, is that the key sign?
Very simple. 6 months of not having a period should be investigated. And that's because there are multiple reasons for that, not just early menopause, that range from overproducing prolactin in the pituitary through to early menopause, through to stress-induced not having periods. And so the rule of thumb, no spontaneous periods for 6 months and not on the pill, obviously, or not with hormonal contraception, you would investigate.
Do you know if someone has had relative energy deficiency syndrome, experienced that, and had amenorrhea? Let's say
had which? Sorry,
REDS. I sent you that the I think I sent you maybe. I'm not sure if I sent a paper,
it's the exercise induced.
Yeah, so exercise induced sort of energy deficiency. Yeah. Typical kind of avatar here is a woman in her 20s or early 30s. She's overtraining, training the house down, undernourishing, and she notices that she's lost her period. So she experiences amenorrhea. If a woman has experienced amenorrhea in her 20s, is she at increased risk of early menopause?
No. But can I just correct that? That picture's often painted. So some girl turns up with not having had a period for 6 or 8 months. And this young woman is 28. She's not exercising ridiculously. She's not underweight. She's normal body weight even. She's not anorexic, but maybe really controls a bit what she eats. But they actually have the same brain changes of the RED syndrome, the girl, the extreme version. Because we keep looking for the extreme version. All you need is chronic subliminal stress and your periods will switch off. So a lot of young, healthy girls who just have this, we used to call it a type A personality, perfectionist, worry a bit about things, maybe a bit under the pump at work, exercising but not crazy. I mean, the exercise might be yoga 3 times a week and Pilates and take the dog for a walk. But a lot of these are missed because people don't realize they have the same chronic low dose stress that is feeding onto the central part of their brain that controls their cycle, and the brain goes, shut it down. So
in that scenario, to help the period resume is to look at what is causing the stress, what's
causing the stress. And if you look at young women with anorexia nervosa, their periods stop well before they lose a lot of weight.
Mm-hmm.
It's not the weight loss, it's the stress.
Mm-hmm.
And so this is often underappreciated. And what we often see is many of these young women are misdiagnosed as having polycystic ovary syndrome, PCOS,
mm-hmm.
because if you scan their ovaries, they have lots of little follicles in their ovaries because they're not ovulating and they're all accumulating. So often these women are misdiagnosed, told they had PCOS, look it up. Oh my God, I'm infertile. I'm going to get diabetes. I'm going to get heart disease. And I'm going to get fat. Then they go crazy, crazier because they're so stressed now.
So what would be like the telltale kind of signs or symptoms or tests that would differentiate and help you determine that, okay, it's not PCOS here?
Their hormone profile looks pretty normal. And one absolutely telltale sign for me is a very unexpected thing in the blood called sex hormone binding globulin. This is a protein that circulates in men and women, made by the liver, and it transports hormones in the bloodstream. It's like the train and carries the hormones around the bloodstream. Women with PCOS nearly always have low SHBG. If the SHBG is not low and someone hasn't had a period for a few months and everything else looks a bit normal, they're very unlikely to have PCOS.
Do women with PCOS, do they experience menopause later? Is it pushed back?
No.
No. Does their experience of menopause, is it likely that it will differ from a woman without PCOS with regards to symptoms, severity?
Not really.
Okay.
No. And in fact, PCOS used to be considered the harbinger of heart disease in later life. And Bart Fauser, who's one of the world experts in this, has shown that after menopause, women with PCOS are not more likely to have heart disease than other women. So it's not as evil as people think, having PCOS.
Quick one. If you'd like some inspiration to take your fermented food game and gut health to the next level, be sure to check out my digital plant-based ferments guide. Inside are some of my favorite recipes, including my soy labneh and homemade kombucha. Learn more at theproof.com/ferments. That's theproof.com/ferments.
I'm sure that's comforting news for a lot of people. Back to early menopause. Something else that I've read online, and I think maybe a few people sent me a question about this, was when a woman enters early menopause, I believe her risk of breast cancer is actually lower than if she hadn't entered early menopause. But that changes a little bit if she was to commence hormone replacement therapy. And I read an article that you posted that provided some nice context for someone who's kind of interested in that.
One of the risk factors for breast cancer is a late menopause, because your breasts have got more and more and more years of being exposed to estrogen and the changes through the month. So if a woman goes through premature early menopause, compared to all the other women in the street of the same age, her risk of breast cancer is reduced compared to them. If she goes on hormone replacement therapy, we will not give back nearly as much estrogen as she would have had as if she'd never gone through early menopause. So you're not increasing her risk like you might be potentially increasing the risk of a 60-year-old taking hormone replacement therapy. You're just normalizing her. So it's just like if you've got an underactive thyroid, you take thyroid hormone to bring you back to baseline. But we don't even bring women back to baseline risk of breast cancer with HRT.
If a woman does enter early menopause and say is untreated and has exposure to low estrogen, it's longer than someone who would enter menopause later. So just to be clear here, and I guess this speaks to the importance of diagnosing early menopause and thinking about treatment options, does she have increased risk of osteoporosis and cognitive decline and cardiovascular disease?
So consistently, studies have shown that menopause before the age of 45, untreated, is associated with an increased likelihood of osteoporosis and fragility fracture early in life, heart disease early in life, and premature death. And as much as we bag the WHI study, that study showed that women who are women who had their ovaries out before the age of 45, who are now over 50 to go in the study, who are allocated to estrogen therapy versus placebo, had, I think it was like a 40% less likelihood of death in the follow-up. So estrogen protects women who go through early menopause. And unless a woman has a contraindication like breast cancer, I don't think there's anyone who would not say if a woman goes through menopause before 45 that they should have estrogen. They really should. It protects them.
Are there any other contraindications other than breast cancer?
Breast cancer or hormone-dependent cancer that's not managed would be the main ones. I mean, endometrial cancer, uterine cancer is a hormone-dependent cancer. So clearly it would depend on the stage it was diagnosed. If it was diagnosed extremely early, woman had a uterus removed, she's had a curative procedure, you would still use hormones. So breast cancer is the big one.
What's the role or potential role, and I think one of your clinical trials may be looking at this, for testosterone for women that have entered early menopause?
Testosterone, we know, can be extremely beneficial for postmenopausal women over the age of 40 in terms of improving libido.
And that's from clinical trials.
Clinical trials consistently have shown that, large clinical trials. Where we completely lack evidence is, are there any other benefits? Because all the studies looking at bone and muscle and heart disease are too small and too short. So presently, we're recruiting women to a study who are under 55, have gone through menopause, are on estrogen, and we're going to look at testosterone versus placebo to look at their bone health, and we'll look at sexual function and muscle function as well. And then the other group where there's a lot of interest is, does testosterone improve muscle function, strength, muscle mass in postmenopausal women? So we're also doing a study looking at women over 55.
Why is that important? Can you remind us of?
So muscle's really important because particularly as you get older, because not only do muscles stop you falling over and stop you fracturing, but as we age, from the age of about 55 onwards, our muscles get infiltrated by fat. And when that happens, when you get, you know what a fatty steak looks like compared to a lean steak. And when it gets infiltrated by fat, we become more insulin resistant, and that's the pathway to type 2 diabetes. So keeping muscles fit and strong and healthy actually protects you against type 2 diabetes, which then protects you against and other diseases like heart disease. So we're looking at whether testosterone has benefits on muscle compared to placebo in women over 55. So we're doing those two major studies, which will tell us a lot about muscle and bone in younger postmenopausal women and older postmenopausal women.
And that's in women presumably that are just going about their everyday life, or are they doing specific exercise or?
No, we just want all comers.
Okay. I did get a bunch of questions from women who either have breast cancer or have had it and are also experiencing vasomotor symptoms. So I bet this is a type of patient that you see all the time. And of course you get lots and lots of questions. And I think we spoke about Q122.
Yep.
Is that how you say it?
Yeah.
Right. And you conducted a study on Q122. Can we perhaps go back over what that is? And I just want to double click on this topic and discuss whether there's any other options that are out there for women in this position who are contraindicated to take estrogen or hormone replacement therapy, but are experiencing the hot flashes, the night sweats, the lack of sleep, etc.
Okay, so the study with Q122 was women with breast cancer who were taking treatments to block the action of their estrogen or stop them making estrogen. And we showed a benefit in terms of hot flashes and night sweats, but it's still in development. So that's not going to be available if it's going to be available for some time. There's another compound, a whole group of compounds that have a different mode of action, and both Q122 and these other compounds act centrally in the brain in the sort of hot flush center. And these are called NK3B antagonists, and they also appear to block the pathways in the brain that cause hot flashes and night sweats. The problem with the NK3B antagonists is that they haven't specifically been studied in women who have had breast cancer. Not because that they might be dangerous, but we don't know how effective they'll be in women who are also taking an anti-estrogen or a therapy. But one of these is likely to be approved by the FDA in the US sometime this year, probably. I think the review comes up in April. So that may be available in Australia in the new feature. It may not be. It hasn't been approved anywhere yet. So what have we left with? Well, we are left with some antidepressants. We call them SSRIs. So the classic would be something like paroxetine, but you can't take that if you're on tamoxifen. And another one well known by its trade name, Effexor.
Tamoxifen being an estrogen blocker.
Tamoxifan's an estrogen blocker, so you can't take paroxetine if you're on tamoxifen, but paroxetine is approved in the US for treatment of hot flushes. And so there are other versions of that that are safer for someone on tamoxifen.
Are there any potential downsides of that medication?
Not really. Some women, they're antidepressants, and some women will say, I feel emotionally numb on it. Other women say, I feel much better on it because my subliminal depression's gone. So I think it varies, and the effectiveness varies. The other one's a pain medication, gabapentin, but that can make some people drowsy. And the one we've been most interested in recently is actually used to treat irritable bladder, oxybutynin. And that can be quite effective for hot flushes and night sweats after breast cancer.
Mm-hmm. Okay, so there's a few options.
There are a few things out there. None of them are great.
And then, of course, lifestyle. So you spoke about the importance of weight loss if someone's overweight.
Yeah, being physically well makes a big difference.
Okay, and I want to come back to tamoxifen. I think this kind of patient population is interested in the vasomotor symptoms, but then also interested in bone density. So I want to talk about estrogen and its effect on bones. But one other question or comment that I had come through, it is a question. If I have BRCA2 positive gene and a complete hysterectomy, can I take HRT? So I think we've been speaking about people with a history of breast cancer. So what do the guidelines say about a woman who doesn't have a history of breast cancer, but perhaps has a genetic predisposition?
So most women today who have a BRCA1 or 2 gene mutation, that increases their risk of breast and ovarian cancer, and some other cancers, will, by the time they get to their mid-40s, have their ovaries removed, and with or without the uterus being removed, but I usually encourage them to have their uterus removed because it makes HRT safer. And usually we'll have a bilateral mastectomy to reduce the risk of breast cancer. And the available data we have is that if you use estrogen-only therapy in that setting, is perfectly safe. There may be a small, very small risk of cancer, because sometimes some tissue is left. And it's a tiny risk if estrogen and progestogen is used. But if a woman's having both her ovaries out for a BRCA1 or 2 gene mutation, I would encourage them to have a hysterectomy, take estrogen only. It's very safe.
So let's come back to the woman who has had breast cancer. She was on tamoxifen or potentially a drug like anastrozole, so something that is stopping the production of estrogen. So I guess my understanding is you've got a couple classes of drugs, some that stop the production, some like tamoxifen that block its action. So I guess my first question is, do the ones that stop estrogen production, like anastrozole, do they have a more significant effect on bone density than tamoxifen?
Totally.
Okay. And so how, in this context or just in general, how is low estrogen actually affecting bone quality density? What's happening here?
So estrogen's fundamental for bone. So you talked about the drugs that are used in breast cancer called aromatase inhibitors that block the production of estrogen. So estrogen's made, to keep it simple, estrogen's made from testosterone. That's why women need testosterone, because if you don't have testosterone, you can't make estrogen.
Right, it converts over.
Yeah. So this enzyme converts testosterone to estrogen right through the body. So there have been a few people, men, with genetic mutations so that their aromatase enzyme doesn't work. And these men have severe osteoporosis, despite having normal testosterone. And just with low-dose estrogen, their bone recovers. That's how important estrogen is in bone. Interestingly...
Speaks to also how silly this idea is that testosterone is the male hormone, estrogen's the female hormone.
Men need estrogen.
Right.
So one particular man who was well characterized, he was tall because his bone plates hadn't closed over to stop him completely growing. He had severe osteoporosis because he couldn't make estrogen. He had a fatty liver because he couldn't make estrogen. He had skin changes that we see with severe insulin resistance and diabetes, these black deposits in his skin. And he had cholesterol buildup in his carotid arteries. And when he was treated with low-dose estrogen, his bone density improved, his fatty liver went away, and the cholesterol buildup in his carotid started to disappear, and the skin changes of insulin resistance started to go away. So this shows you what happens if you don't have estrogen.
Which I think kind of emphasizes the concern that some women who have undergone this treatment to reduce the recurrence of breast cancer, where they've had estrogen lowered, are worried about, of course, very happy to not have the recurrence of the cancer, but are worried about what are the knock-on effects and what can they do.
So the important thing is bone health and monitoring bone health. And in fact, we are calling for the Australian government to make bone density studies for women in that setting rebatable. And then metabolic health, keeping an eye on your cholesterol, exercising, good diet, do whatever you can to have a good metabolism.
But from a bone density quality point of view, is this where other classes of drugs?
We'll often use another class of drug.
And what would some of those be?
We'll often use bisphosphonate. We'll often use what's called a bisphosphonate. The most common would be alendronate or residronate in that setting to protect the bones. We will do what we can to protect the bones.
Is there a difference between an oral and a kind of IV bisphosphonate?
They basically do the same thing. I mean, is there a difference? There's a difference on how long they last in the bone, how many doses you have, but it's a variation on a theme.
I had a question come in, and this is quite a specific question. It was a woman in this who went through this experience we're discussing here, who was taking Prolia, so another class of drug, to help with bone density. And she was curious if she was coming off Prolia due to side effects, does she need to start on bisphosphonates straight away?
Yes. We don't tend to like Prolia for youngish women. And by youngish women, I'd say healthy women under 80 even.
How does Prolia differ to a bisphosphonate?
So Prolia is what's called a monoclonal antibody. So it acts against an enzyme in the bone that causes bone reabsorption. So both bisphosphonates and denosumab, which is Prolia, reduce bone reabsorption. So you get more formation relative to absorption. But ultimately, they will reduce overall bone. Bone's living tissue. It's constantly turning over. So it does sort of reduce bone turnover. Prolia is given as an injection every 6 months. But what we know is that 6 month is a very tight window. You don't want to vary that 6 months by. So if you do it for it in August, you don't want to have it in January. You need to have it within a couple of months of your due date. And that's because when you withdraw the Prolia, the bone reabsorption seems to crank up very rapidly.
So you lose a lot of the gains.
You lose the gains very rapidly, but in doing so, you become much more vulnerable to fragility fracture. So there is a high risk of fragility fracture. There is an increased risk of fracture by just stopping Prolia.
Are you worse off than if you had never started Prolia?
Potentially. So we tend to give it with the belief that this is a person I'm going to give it to and I don't need to stop it.
How's it tolerated?
It's mostly tolerated very well, but you ideally don't want to stop it. And that's fine for some patients. We've got some patients we have no interest in, they're 85, we're going to keep them on Prolia.
If it's not tolerated, what would someone report? Like this example of this woman.
Some people get rashes, for example. Okay. The most common would be a rash.
Right.
So in contrast, if you take the bisphosphonates, alendronate, risedronate, the infusions alendronate, it builds up in the bone. So when you stop the dose of it, there's a very, very gradual decline. So after 3 infusions of alendronate, that's good for another 3 to 5 years in your bone, maybe longer. After the oral therapies for a few years, they hang around in your bone for 1.5 to 2 years. So there's a slow offset of the effect. So you don't get that acute risk of fracture. So when we're going to stop someone on Prolia, we usually jump in and give a zoledronic acid infusion very quickly to try and, but that may not absolutely protect. But there will be there'll be a drop off. You'll lose the bone you gain.
Mm-hmm. And which you'll see, it'll show up on a T-score or something like that.
Oh yeah, the bone density shows a rapid drop. So, for example, my age, if I had low bone density, I would not be a candidate for Prolia. You would want to put me on something, a bisphosphonate. If I take it for 3 years, my bone density normalizes. I can stop it. It will drift down again. I might start it. You can on and off it.
Okay, so you're just monitoring it via a DEXA scan, looking at those scores.
Yeah.
Okay, so you're not necessarily on that for life. If a woman's listening and thinking, gosh, I've just been diagnosed with osteopenia or perhaps just on the borderline of osteopenia and osteoporosis, she can actually improve that and move back towards normal.
I mean, most of my patients will get up towards the normal range and then we'll even stop medication for a year or two. Mm-hmm. It's quite common.
Okay, that's good news. And outside of those drugs that we mentioned, another one that I have come across, Evista or raloxifene.
Raloxifene is a selective estrogen receptor modulator. So imagine that the estrogen receptor is like a pocket on a billiard table. We describe it as promiscuous because it will take a red ball or a white ball or a black ball. It doesn't care which billiard ball falls in. It will take them all. And so lots of things can sit in that pocket. So SERMs can sit in the estrogen receptor like estrogen, but they have different effects. And the way it sits in the pocket, we would say the conformation, but the way, if it's like a triangle in the pocket instead of being a ball in the pocket, it might trigger different responses of the estrogen receptor. So it can block the estrogen, sit in the pocket, but block the estrogen receptor.
Like a soy isoflavone, sort of.
Sort of. And so we've got the funny shaped ball falling in the billiard pocket, but it doesn't end there. Then what happens is other enzymes come along and either switch on or switch off whatever that billiard ball's doing in the pocket. And that varies between tissues. So raloxifene acts like an estrogen in bone, where it has the right enzymes to switch it on as an estrogen with the shape it takes in the billiard pocket. Or in breast, it blocks the effects of estrogen, even sitting in the same pocket, because it's selective estrogen receptor modulator.
So is that a good thing?
Sorry?
Is that a good thing, or are you saying that can
It's
be
a good
bad
thing because it modulates the estrogen
Mhm.
receptor selectively in tissues. Tamoxifen, which we talked about before for breast cancer, is a SERM, a selective estrogen receptor modulator. It acts like an anti-estrogen in the breast, but it acts like an estrogen in bone and the uterus. So raloxifene predominantly acts as an estrogen in bone and an anti-estrogen in breast. It was originally introduced to treat bone.
Just to clarify something there, raloxifene acts as estrogen in bone, anti-estrogen in breast, but tamoxifen
It's the same.
is the same.
Yeah.
So why does tamoxifen, does it lead to decreased bone mineral density? Or not so much?
Not as much as it can protect. It can potentially protect. So raloxifene was introduced initially to prevent bone loss and a treatment for osteoporosis. But in fact, it's not used much for that because it's not that good. But it is used, particularly in the US, to prevent breast cancer in women at high risk of breast cancer. But it's not used to treat breast cancer.
So clinically, bisphosphonates, would they be the
mainstay?
They'd be the mainstay.
They're still the mainstay.
Okay. And outside of all of this, a woman's sitting down with you and she says, from a lifestyle point of view, and I think you kind of broadly mentioned nutrition, exercise, but are there any specifics that you would give her and say, look, these are the biggest levers that you can pull if you're going to focus on a couple of things?
This is after breast cancer.
This is a woman, let's just say any woman, who is interested in lifestyle changes that can improve her bone mineral density.
Oh, improving bone mineral density, multimodal exercise. So walking the dog is not exercise. I mean, it's sort of exercise, but it depends on the dog. If you're jogging with your dog, that's exercise. Strolling around the park with your dog's not exercise. Putting on your lycra and going for a leisurely walk with your girlfriend is exactly that. Unless you're hot and sweaty, it's not exercise. And it's not going. And walking doesn't really help your bones. Walking's just a good thing to do. To get your cardiovascular system going, you've got to get a bit hot and sweaty. And to help your bones, you've got to do something that involves a range of different movements. So that's what we call multimodal. Involves weights, involves hopping, skipping, and jumping. So bounding up and down, could be Tigger exercises, or a combination of these. And that will help bones. But unless you're doing that really regularly, all you're doing is doing something nice.
Yeah, my mum is actually in a clinical trial at the moment. She won't mind me mentioning this, with Deakin University, looking at a multimodal exercise program versus a kind of standard care approach.
Yep.
So
probably Robin Daly's thing.
Yeah. So it's good that people are kind of studying that to see what is the effect on bone mineral density.
Very important.
Let's slide over to questions that I got about other symptoms. And this one actually came through a few times. Is it true that shorter menstrual cycles in a woman's reproductive years is associated with more severe menopausal symptoms later in life?
It's a new one on me.
Okay. We'll put that one down to social media. And then there was a follow-up question. Is this the same for an intrauterine device?
No.
Okay. As in, there's
no
increase
in
risk.
The intrauterine devices release, well, some are non-hormonal and just sit there and are mechanical in their effects. And other ones release hormones into the uterus to stop implantation of an egg. And they don't do anything to the ovaries. The ovaries just tick along as normal.
Right. So either of these scenarios, there's no evidence to suggest it's going to affect menopausal symptoms or timing of menopause, etc. Question: why do we get night sweats? What's causing that?
How long do you want me to take to answer this question? There are cells in the brain called kindy-neuron. There are cells in the brain called kindy-neurons. And they're called that because they release a range of hormones or chemical messages, kisspeptin, neurokinin, and dynorphin. Neurokinin I mentioned before, with a new medication that's been developed to block hot flushes. And kisspeptin is actually one of the central chemical messengers that controls the onset of puberty and the ovulatory cycle, as well as what happens at menopause in terms of hot flushes. And these nerve cells at menopause actually get bigger. And it seems they maybe become more active, and more neurokinin 3B is released, and that goes down a pathway that activates the thermoregulatory center in the brain. And in that center, when you get this change in these nerve cells, more of this neurokinin 3B being released, triggering hot flushes in some pulsatile way. Why exactly does this happen? We don't know. There are all sorts of diagrams that we draw and clever hypotheses we make and studies done in rats looking at the temperature of the rat's tail, but we don't really know exactly. And why do some women have a hot flush response after menopause and others don't? And why do some women have terrible hot flushes for 6 months or 12 months or 2 years, then they go away, if nothing else has changed?
So there's no patterns whereby, say, women who are exercising less or eating a less healthy diet or are more overweight have worse?
Women are at a greater increased risk of hot flushes and night sweats if they're overweight or obese. And exercise doesn't seem to come into the equation. If they're smokers, they're the most common, the greatest links we can see. Okay.
And so you mentioned, what was the name of that drug before that you mentioned?
Oh, the neurokinin 3B antagonists.
Okay, got you. And is there an actual sort of brand name?
Oh, Fesolantant.
Got you.
Is the one that's under review.
Mm-hmm.
There have a number have been developed that have not progressed because they've ended up with unwanted side effects, and several are in development. But being mindful that all they do is reduce the hot flushes, night sweats, and improve sleep as a consequence, but they don't do anything for mood changes, anxiety, vaginal dryness. So they're not an estrogen. They're just acting on the hot flush center.
And estrogen, though, just to kind of re-emphasize something, can also reduce these night sweats.
So estrogen feeds back onto these cells that, let's say, go rogue after menopause and calms them down, and therefore you get reduction of hot flushes and night sweats.
This is perhaps one of the symptoms where the complementary medicines, alternative wellness space pops up. Are there any complementary medicines, herbs, alternative options here that have proven safety and efficacy for night sweats, hot flushes?
So we've just reviewed all the international guidelines, and there's agreement that phytoestrogens are not helpful. There's agreement that the majority of things that have been tried are not helpful. Acupuncture in placebo-controlled trials has not been helpful. Yoga is not helpful. Black cohosh is considered unhelpful and helpful by different recommendations. With black cohosh, there's for all of these things, there's a big placebo effect. Black cohosh appears to be perhaps a bit helpful for women with not very bad symptoms. So it's been shown to maybe have a benefit in women with very few hot flushes, mild symptoms. But if you've got raging hot flushes, night sweats, no. Cognitive behavior therapy has been shown to help women cope with the events. So when they start to get the hot flush, getting less overwhelmed, dealing with it better. But basically, no. You wouldn't want to spend your money on most of these things.
Right. So soy isoflavones and soy foods. Because I think I've seen a couple of studies, but is it just that there's not enough evidence?
No. Quality of studies have shown no benefit. The really good studies show no benefit.
Okay. That's interesting. I think that'll be news to some people who have heard otherwise.
It was all a rage in the 90s, and we did all these studies and we showed no benefit. Other people showed no benefit.
Is that with phytoestrogens
estrogen isoflavone supplements or soy foods themselves?
Both.
Interesting.
Quick one. A lot of people ask me for tips on buying supplements and getting blood tests. I've created zero-cost guides for both of these, which you can download from my website, theproof.com.
What about the health of someone's thyroid? Can an untreated thyroid condition or an existing thyroid condition that is treated, can that play into the menopausal symptoms that someone experiences?
So a lot of the symptoms of overactive thyroid or even underactive thyroid and menopause overlap. So fatigue, anxiety with overactive thyroid, sweating with overactive thyroid, fatigue and weight gain with underactive thyroid. So we always check thyroid function in women across ages because thyroid disease is common and it can masquerade as many things. The only link would be that women with autoimmune thyroid disease are at greater risk of having autoimmune early menopause. But the risk is still small. The majority of women with an overactive or underactive thyroid will not have an early menopause, but that's the only link. There's no other link.
And I got your coffee on your way in today. Often coffee comes up, and we might have spoken about this last episode. People talk about adrenal fatigue.
Oh, don't go there.
We did speak about it briefly, but let's go back to it.
I get fatigued when I hear about adrenal fatigue. Is really, I'm seeing less patients told they've got it now. I think it's gone out of vogue, but it was very in vogue a few years ago. So someone goes to their doctor saying, with this whole list of symptoms. You've got adrenal fatigue, and then they put on a bit of hydrocortisone. They feel great. Well, everybody feels great if they're put on hydrocortisone. Your adrenals are incredibly robust. If you've truly got a dysfunctional adrenal, you are not a well person. Your blood pressure is really low. You can't fight off disease, or your body doesn't respond to health stresses. It's very easily, it's clearly diagnosed, but most people who are told they've got adrenal fatigue have got very normal, healthy adrenals.
Mm-hmm. So for most people, they don't need to be fearing coffee.
No, I'm not sure about the coffee link and adrenal fatigue, but
yeah, there's these comments that I see quite a bit around caffeine causing adrenal fatigue. So
no,
good to clarify that. We spoke about depression in the last episode, and one thing that you made clear was we have to be careful not to attribute all depression in the postmenopausal period of a woman's life to changes in hormones. Can you elaborate on that?
So over the last few months, there's been this whole surge of interest in menopause, and being mindful that I've worked in this space since the mid-80s when I started working in Australia's first menopause clinic. Not that I didn't set up, I was a new trainee in the clinic. So I've been around doing this for a long time. And suddenly there's this huge surge in menopause and awareness of it. And it's very easy, and I understand how it happens, that women attribute almost every symptom that they're experiencing to the menopause. Joint pain, brain fog, mood changes.
Weight gain, would that fall
weight
into
gain,
it?
Depression. I can give you a shopping list of symptoms. Dry skin, dry eyes, dry hair, hair falling out, teeth not as good. I've heard them all. And we have to be very careful not to attribute everything to the menopause. And the reason I say that is not that I don't care about women. I care about women very much. But what happens is then you don't diagnose what the real problem is. We don't want women going months to years being treated for menopause for their joint pain when they've got progressing rheumatoid arthritis. We want that diagnosed and treated properly, or joint lupus or psoriatic arthritis, or thyroid disease, which is usually easily detected. And we don't want women who truly have biological depression and mental health issues, true anxiety, being told it's all menopausal, dear, just take these hormones and you'll get better. We have to be very careful. Depression is common and every woman gets menopause. And these other things I've talked about are common, but we want to make sure we treat women properly for the root cause of their problem.
So where does a woman start on her journey, I guess, towards advocating for her own health if she's experiencing poor mental health, in trying to unravel that and work out what is the root cause? Is it the fact that I'm not on hormone replacement therapy? Is it other factors in my lifestyle?
Well, I think it's about being honest with what's happening in your life, and sometimes it's very hard to be, and we all want to put our head in the sands at times. And a classic would be sexual dysfunction. Maybe that's an easy one to talk about. I see a lot of women who present with sexual dysfunction. Will testosterone help me? And occasionally we'll get to the point they'll treat someone, they'll come back, they'll tell me it hasn't worked, but then they'll say, I've realized it really is my relationship. Now, I can talk to them till I'm blue in the face, until they tell me what's happening in their relationship. I could ask them every question. It might seem that their relationship's good, but until they identify what's going on between their four walls, they can't even share it with me. And often it takes treating someone in that situation before the real problem's identified. Depression is a little bit more serious in a way, because we don't want a woman sinking into depths of depression and keep saying, oh, we'll just up the dose of estrogen, we'll just up the dose of estrogen. So I think it's a matter of the woman identifying, how long have I been feeling like this? Did this really just start when my periods changed? What else is happening in my life? And usually often it's the perfect storm. Pressure at work, job dissatisfaction, worried about kids or elderly parents, and the onset of menopause. Mm-hmm. So estrogen might help a bit, but it's not going to fix everything else.
And indirectly play into potentially some other behaviours that can affect mood.
Yeah. And I can assure you that we know that around this time of life, women start to drink more alcohol and have other behaviours that perhaps are not good for them.
Have there been any trials that have looked specifically at estrogen therapy and depression and tried to tease out, for what percentage of the population is it effective?
Certainly, studies show that mood and well-being will improve if you treat hot flushes. I'm not aware of any quality research that's looked at women with perimenopausal or early postmenopausal depression not having hot flushes. Because if you don't sleep, you're depressed.
Let's double click on weight gain. And we spoke about this previously. We spoke about the fact that fat cells, particularly around the abdomen, can produce a little bit of estrogen. So there's perhaps this physiological change during menopause where the body's trying to hold on to some of that. As the ovarian function declines and there's less estrogen produced there. And I was reading one of your papers on weight gain, I think, was that 2012 or 2013?
Weight gain at menopause.
Yeah, sometime around then. And you kind of really nicely pointed out that certainly fat distribution seems to be able to trace back at least partly to changes in hormones and menopause, but sort of total body weight perhaps not. So can we kind of explore that area and provide us a bit of a synopsis, I guess, as to what you found when you wrote that review?
So studies, doesn't matter what country they're done in, show that on average women increase their intra-abdominal fat by 20 to 40% through menopause, even if their weight doesn't change. So we shift weight to our bellies.
Which is a problem because that's the more sort of metabolic damaging
That's the bad
type
fat.
Of fat.
That's the unhealthy fat. But really well done studies that have followed women every year with body composition measurements. The SWAN study, the Penn Aging study, and other studies have shown that the weight gain women complain most about menopause is actually an age-related weight gain creep that starts around later reproductive years and is not due to menopause per se. It's It's an age-related creep.
As in, it's not specifically due to this change
It's
in
not due to the
hormone
change in
level.
hormones.
Right. So then what do we understand what is causing that creep?
Mostly lifestyle.
Mm-hmm.
And I guess what exactly, we don't know exactly. What do I hypothesize? Your life changes, you know. The average 54-year-old woman is not running around after a 3-year-old or even a 12. I mean, some still are running around after 12 and 14-year-olds, but the majority of us who have had children, the kids can look after themselves by the time we're going through menopause. And it's about lifestyle. It's about being less active. A lot of it's about being less active, bad food. I mean, look at the population. So we studied 7,000 women aged 18 to 39 in Australia. They're representative of the Australian population. 45% are overweight or obese, aged 18 to 39-year-old women. Fast forward 10 years, what are they going to be, you know? And so it is a whole societal health issue. It's an age-related weight gain creep that occurs. And as we get older, our metabolism slows. So there's so many reasons. It's mostly not menopause.
Do women that come in to see you clinically find that hard to believe? Because I think, you know, the common sort of question or comment that I get is nothing's changed. I'm eating the same.
But it has changed. Firstly, you're older. And as we get older, our metabolism is different. And secondly, I think our lifestyle's changed. I mean, gosh, I've got a car that I just go near it and I can open it. I don't even have to lift our lives have changed.
But it's not just about accepting it, because what I'm hearing from you is that there are things that a woman could do to reduce visceral fat and some of those changes.
I saw a patient about a year ago. She came in, she said, well, I need to tell you, Dr. Davis, I wasn't going to come back to this appointment. I said, oh, really? Yes, I wasn't coming back. In fact, I was horrified. I left and didn't want to pay the bill, and I went and spoke to my own doctor. I said, oh, I'm really sorry if I upset you. She said, yes, because you told me I was overweight. You told me I needed to lose some weight. I actually felt quite good when I came in here. And I said, oh. And she said, and I've lost 8 kilos and I feel fantastic. Because I went to my doctor and my doctor said, well, I didn't want to say that to you, but, you know, Dr. Davis is right. And I mean, she wasn't obese. She was overweight. And she said, I did lose the weight and it wasn't that hard. But it's not politically correct to tell somebody they're overweight. I mean, you asked me, we talk about hormones and breast cancer. Women who are overweight have a 20% increased risk of breast cancer. And if they're obese, it's 40% increased risk. Hormone therapy doesn't increase. The worst outcome study hasn't shown a 40% increased risk. So
puts it into perspective.
Yeah, and it is not healthy. As a society, we are overweight and obese.
So how do you feel about talking about being overweight, being politically incorrect, and what's the way of kind of navigating that and
I think it's
moving
acknowledging
forward?
It is not healthy to be overweight or obese. And I think that, and I say to patients, don't go on some crazy diet.
So what about the person who pushes back and says, well, Dr. Davis, I've heard that you can be obese and be metabolically healthy.
There was this sort of trend for the metabolically healthy obese person. That's all gone out the window. It's been disproven. It's not metabolically healthy to be overweight or obese. And listen, believe me, I don't think it's easy to be, I'm not saying everyone should suddenly be skinny, okay? We have sociocultural factors that discriminate against people having the opportunity to be healthy as they want to be.
Sure.
you're a single mother with 3 kids. You got to get up. You go and work in a call center all day. You get home and it's dark. You start cooking dinner. What hope have you got?
If you have time to cook,
yeah,
could just be takeaway.
And you probably just buy the cheapest thing you can buy.
Mm-hmm.
Okay, so it's not easy, and I think it's a community issue. It's not an individual issue. That's why I say 45% of young women are overweight and obese. No one's being bad. No one's exhibiting bad behavior. We have to do it better as a community.
Yeah. So you're not saying to blame the individual.
There is
you're
no
just saying
blame.
we shouldn't sweep this under the carpet.
We should talk about it and say we got rid of smoking pretty well. That was a community effort. What can we do to make healthy foods more available? What can we do to make physical activity more available to people? And I think it's not an individual blame thing by any means. I wouldn't like anyone to interpret me as saying that.
Yeah, I think some of that metabolically healthy overweight research was misrepresented, because it is true that you could have 2 people who are both overweight, but one has more visceral fat and perhaps has higher risk. But that's not to say the other person would not be lower risk if they lost some weight.
Exactly.
Okay. So if a woman is listening to this and saying, okay, this is great, I realize that I need to lose some weight. We spoke last episode about estrogen therapy perhaps having an effect on visceral fat. Is that right?
Potentially, yeah.
Potentially. So it could reduce some of that sort of change in fat distribution. What else? What are the main things that a woman can focus on who is thinking, my life really hasn't changed that much, but I would love to lose some weight?
I think a couple of things. Being physically active obviously is important, but you have to jog for 20 minutes to burn off a glass of orange juice. You have to do a lot of exercise. Most people can't really do enough exercise that will really burn the calories. So it's really being very honest about what you put in your mouth and just changing a couple of small things. 30 years ago, we weren't drinking a couple of lattes during the day. We were just adding a bit of milk to our coffee. You have a long black coffee with a bit of milk in it. Now we have a little bit of black coffee with a lot of milk in it. Small things like that. Just changing. I just suggest people identify a couple of small things they can change and gradually drop some weight, not try to lose weight in a big hurry.
There's a big conversation right now, particularly in the States, around semaglutide, this GLP-1 agonist for people that really are struggling to lose weight and perhaps have an appetite that they can't curb. Do you see a role for those types of drugs to help people lose weight?
I definitely see a very clear role for the new weight loss drugs that were originally developed for treating diabetes. They can be incredibly beneficial. But for someone who's like 5 or 6 or 8 or 10 kilos overweight, they're much better off to change their diet and exercise a bit more to lose weight, because when you do it that way, you keep it off. The problem with the injectables or the SGLT2s, etc., is that I've seen people lose, say, 5 or 10 kilograms on them and they stop the medication, they gain the weight again. Well, if you're only 5 to 10 kilos over, you're probably better to just lose it naturally. For people who have become extremely overweight, they're just a godsend, because you can get to the point that you just don't know where to start to lose the weight. And the confidence building this can give people, and that they can actually control their lives, is amazing. So I think they're great drugs, used appropriately.
There was quite a few questions about sex and pain during sex. We touched earlier about testosterone for sexual desire, but what is it about menopause and the changes in hormones, if it is hormones, that could lead to vaginal dryness and pain during sex?
Well, the vagina, the neck of the bladder, the genital tissues are highly estrogen-sensitive tissues. So when estrogen levels drop, the lining of the vagina thins and dries out. The actual type of cells we see in the vaginal tissues changes. And so having sex, when we'll say, I feel like it's tearing, it's painful, There's no more lubrication, and often they get urinary tract infections. And it's very simply treated with vaginal estrogen. So either a tablet, pessary, or a cream can be inserted into the vagina. It's not absorbed throughout the body. It acts locally in the vaginal tissues and on the neck of the bladder, and that will reduce the vaginal dry. It will restore the tissues back to how they should be.
So if that's her only symptom,
You use vaginal estrogen.
Whereas if a woman has that plus night sweats, hot flashes,
you use systemic, whole body medication,
and it will help with the vaginal dryness as well.
Sometimes, quite often, women on, say, an estrogen patch or a tablet still needs to have some vaginal therapy as well. It's quite common. So the other urinary symptoms we see, urinary tract infections, and without the estrogen, and your urge incontinence, so that feeling like you've got to rush to the toilet, or irritable bladder, and that can improve quite dramatically with vaginal estrogen.
Quite a few questions came in around changes to hair quality or hair loss, adult acne. Are these other things that patients would present
stress. With? Hair loss is common. The most common reason for hair loss is stress. The next ones you start to look at are iron deficiency, thyroid disease, and then hormones are way down the list usually.
And I think last episode, this comes back to hormone replacement therapy. I may have conflated bioidentical hormones and compounded hormones. But then I was reading the NAM's position statement, and they kind of outline that these are not the same things necessarily. So you can have kind of government-approved drugs that are bioidentical, or you can have compounded drugs that are bioidentical, but their recommendation is to go with the government-approved ones. Can you kind of speak to that and what the rationale is for going with those versions of the drugs, and how someone would know what those versions are versus a compounded version?
Well, firstly, ask the doctor what they're prescribing. Is this is what you're prescribing like my body mix? So if we have estrogen as a patch, a gel, or a vaginal cream, or a vaginal tablet, it's body identical. So our ovaries make estradiol, and we actually make three major estrogens: estradiol, estriol, and estrone. But the main one's estradiol. If a woman is using a patch or a gel that's prescribed by a doctor and dispensed by the pharmacy, already made up, it's not compounded, it will be estradiol, and that is identical to your body. So bioidentical or body identical or human body identical are the words I guess we could use. So you can get human body identical, government regulated approved estrogen, progesterone, and testosterone. There is no need to have these compounded. Compounded is if I say to a patient, I'm going to write you a prescription and I'm going to put so many milligrams of estradiol and so many milligrams of progesterone and so many milligrams of that. You go off to the chemist and it will either be made up as a cream or usually either a skin cream or something you suck as a tablet. They call it a troche, but a lozenge or something. The difference is that company X makes an estrogen patch. They have to keep producing quality control and assurance that every estrogen patch contains exactly the same amount of estrogen. And even to get it to market, they've had to done studies that shows how much is absorbed in women and what is the lowest effective dose that will treat the majority of women.
Those are the ones that NAMS would refer to as government approved.
Yeah, and in Australia ours are approved by the Therapeutic Goods Administration or the TGA.
But compounded hormones are not approved by the TGA.
I can write you a script now. Arsenic and honey, 3 tablespoons daily, put onto your rash, and you can go to the pharmacy and they will make that up for you. They might actually call me and say, are you serious? But no one can stop me doing that. And the only reason I can put any dose of, for you, I could write a prescription for testosterone in cream, go and get it. And there has to be no evidence that will even be absorbed. You could pay $200 for a tube of cream. I've told you it's testosterone. There's no proof it even gets past the top layer of your skin, or there's no proof that I'm not over or underdosing you because there's been no dose study. There's no study. It's a guess.
Okay, so I think that clears things up because I think there probably are many people who, like me, I presumed that compounded meant bioidentical, and the ones that are government approved that your doctor would prescribe more off the shelf were not bioidentical.
Most of what I prescribe is bioidentical.
Okay.
It's just not compounded because I like to be sure that if I'm giving somebody, and I tell you what becomes really important. If there is, there are combinations of therapies, if there's estrogen and progestin in a tablet, that they have done studies that this dose of progestin will protect the lining of the uterus.
Or you could have an increased risk of cancer.
Or you could have an increase of thickening up the lining in cancer. We don't know what doses of the compounded progesterones out there are being absorbed, and are women getting adequate protection of the lining of the uterus?
So why have compounded hormones become, they appear to be somewhat popular?
Everything's always, in the end, money.
Talk to me about diet. We spoke about exercise. You spoke about the multimodal kind of exercise being something that people should focus on, particularly for their bone health. Have there been, when you reviewed the kind of evidence to make the guidelines, the latest guidelines you were involved in, have there been any good clinical trials looking at different dietary patterns or different ways of eating, be it high fat, low fat, ketogenic?
For menopausal symptoms?
Yeah, for menopausal symptoms.
Not really. North American Menopause Society did a series of studies, the McFlash studies, where they looked at exercise, they looked at yoga, they looked at acupuncture, they looked at a whole lot of lifestyle modifications. But I don't think, other than phytoestrogens, etc., I'm not aware of that a vegan diet's been studied compared to a paleo diet, or I'm not aware of a substantial study showing a benefit
for symptoms. So, given the risk of cardiovascular disease, also thinking about dementia, there's osteoporosis to think about, there's dyslipidemia. Do the guidelines kind of just recommend a sort of Mediterranean, high fiber, low saturated fat style eating pattern, or do they not recommend anything?
Most guidelines, the problem is how much can you put in the guideline. So most menopause-specific guidelines focus on very specific hormonal and non-hormonal therapies, complementary therapies, etc., and what the evidence is for in terms of lifestyle behaviors, but not specifically on diet. And again, to be applicable globally, the diet you're going to eat in India is going to be very different to the diet you're going to eat in Brazil versus wherever else, Africa. So I think just in terms of guidelines of it's healthy eating, of what's appropriate in your environment and your culture.
Were there any specific nutrients, supplements, vitamins, minerals, or deficiencies that were associated with increased severity of symptoms?
No, but what I do see quite often is people who are vegan who are zinc deficient, and that's not good for your bones. Zinc deficiency is associated with osteoporosis and anemia. So please, any vegans listening to this, make sure you're on your right nutritional supplements, because it's very, again, being a vegan in India is very different to being a vegan in Australia, and we get more deficiencies here, but they do have deficiencies there.
Zinc, B12,
zinc, B12,
protein,
iron, magnesium.
And resistance training. What about this idea of endocrine disruptors and sort of avoiding drinking out of plastic bottles, BPA, phthalates, things of that nature, or reheating food in plastic containers? Is there evidence that these sorts of, lifestyle changes could affect the symptoms that someone's experiencing?
I'm not aware of any research specifically looking at menopause, but I think the environmental concern and the personal concern of endocrine disruptors in the things you've described do matter. And personally, I choose parabens and phthalate-free soaps, shampoos. Our cleaning products in the house are as ecological as we can manage. So these things are things we should be aware of. And endocrine disruptors in the whole food chain affecting animals in the food chain as well as us directly and indirectly are very important. And I think being conscious of that and using plastics is very important.
Was there anything that we didn't discuss today that, or in our last episode that you wanted to add to our list or expand on?
I think it's really important that people can be as knowledgeable as they can about their health. Take ownership of your health. Be thoughtful about who you believe. Be a discerning consumer of health information, because navigating health information today is harder than it's ever been.
Do you have any tips for that in terms of how someone could recognize that someone is credible?
If someone's trying to sell you something, I'd think twice. And look at the motivation of why is this important? Why is this person choosing to impart this information at this time? What is their motivation for this? And there are a hell of a lot of people jumping on the menopause bandwagon at the moment. It's just become so flavour of the month. I don't know why. After years of no one talking about it. And so I think it is, again, be a discerning consumer.
We need to get people like you out there more to balance some of the conversation that's taking place. What about if someone wants to go away and read a reputable set of guidelines or further information about this topic? Where are the best places that we could send them?
Well, the Australasian Menopause Society has fantastic leaflets, for health leaflets related to menopause. They're all evidence-based. They're really good. The International Menopause Society has information in multiple languages on their website, which is very good. Every year, the International Menopause Society has a white paper. So a lot of your viewers, listeners would be really interested in that. The International Menopause Society, just Google that. White paper for 2022 was on menopause and cognition. And it's freely available. All their white papers for every year, freely available. Before that was bone and muscle health. Before that was sexual function. Weight loss at menopause was weight management in menopause was 2012. But every year there's a major topic. Freely available, multiple languages, all evidence-based. So I think people would find those really useful. They're not necessarily highbrow because they're for a whole range of knowledge, baseline knowledge of even healthcare providers, they're not just for specialists.
Cool. Well, for those that are watching on the video version, they'll see those on screen now, and we'll put the links to those into the show notes. Something else that I just thought about is, there's so much information to this, and it can be potentially overwhelming for someone who's listening. Maybe they haven't even reached perimenopause and they're thinking, wow, I have to deal with this, really? And then there's someone who's already there who's just overwhelmed by all of the different things we've been discussing. Are there community groups or places where people can kind of get together and connect who are experiencing similar things?
There is a really good Australian menopause Facebook group that I think if you just, again, look for that on Facebook.
We'll find it and put it in the show notes.
And certainly in the UK, there are menopause cafes where people get to talk, and I think they're sort of being established in Australia. That would be the main community groups I'm aware of.
And remind people how they can connect with you online and stay up to date with the clinical trials that you're doing on testosterone and just see what you're up to.
So we are part of Monash University, but I lead what's called the Women's Health Research Program at Monash University. And you'll find papers we're publishing, what we're doing that's new, our research trials for people who want to participate. And as I said, for actual consumer health information it's the Australasian Menopause Society. But we complement that because all our research is there on our website.
Susan, this has been great. Thank you so much again for sitting down with me, and I appreciate your time, and all of us appreciate you sharing all of your knowledge with us. So thank you again.
Oh, it's a pleasure. I hope it helps people.
It will.
There we go, friends. Thank you for showing up and the effort you're making to take better control of your health. I look forward to hanging out with you again next week for another episode.